Borderline personality disorder, otherwise known as BPD, is an emotional regulation mental illness. Symptoms of this disorder may be presented quite similarly to other psychiatric diagnoses such as anxiety, schizophrenia, and other personality disorders. 5 of the 9 following elements must be met in order to be diagnosed with BPD. Because there is oftentimes comorbidity with other mental health diagnoses, BPD patients can be admitted to acute psychiatric care facilities prior to understanding that they have what is known as cluster B traits for symptoms of other mental health illnesses. This synthesis project addresses a new policy or plan that will help decrease the rate of acute psychiatric hospital readmissions for adolescents diagnosed with borderline personality disorder. Proper diagnosis and treatment is crucial in the management of BPD. Medications alone do not cure this disorder as it branches from a personality ailment. Group therapy, individual therapy, and psychotherapy are the key components which contribute to the safety and treatment of adolescents diagnosed with BPD. In particular, dialectical behavior therapy, or DBT, is considered the gold standard. Acute psychiatric floors do not offer such programs. This is because DBT must be provided twice weekly for a lengthy period of time to receive positive effects. The more often a BPD patient is hospitalized, the more he or she is missing his or her necessary treatment. After the first admission and discharge of the borderline patient, how would further hospitalization be effective when there is substantial evidence relaying that this chronic disorder is handled with outpatient care? Summarized by Schmeck and Schuler-Moeller, the profile of problems characteristic of BPD is likely to generate a negative bidirectional interaction between the person and his or her social environment, where the supportive, resilience-enhancing properties of the social environment are negated, leaving the individual exceptionally vulnerable to both the social and biological risk. This includes inpatient acute care. This particular project involves the RN leader to think creatively as opposed to manipulatively or deceitfully when discharging a person with an extremely difficult mental health diagnosis. Readmission of the BPD patient may result in regression of unhealthy behaviors such as non-participation, drug or alcohol abuse, sexually acting out, or disruptive behaviors such as self-harm, violence, and rule violation. Instead of the acute unit providing a safe environment like the first admission, readmissions more so enable the child to engage in disturbing acts due to his or her perceived comfort level on the unit. Readmissions are very contradicting to the therapy actually needed for borderline patients. The strongest predictor of inpatient rehospitalization is previous psychiatric hospitalizations. The probability of BPD patient readmission to a psychiatric hospital within 10 years of first admission is 80%. Long-term hospitalization of patients with BPD has limited value and can have adverse effects, for example, regression, repetitive admissions, and increased costs. Successful use of psychotherapy can result in a reduction of up to 80 to 90% in the need for hospitalization, emergency department visits, use of medication, and a 50% reduction in episodes of self-harm and suicidal behaviors in patients with BPD. DBT improves self-control, increases agreeability, conscientiousness, and overall functioning, and may reduce anger and anxiety. Deliberate suicidal gestures and self-harm in adolescents with borderline personality are associated with increases in parental financial burden of $38,000 and $17,000. The first aim of this project is to implement an individualized discharge safety plan for a total of 3 months to decrease the reevaluation and readmission rates within 1 month post-BPD discharge of acute inpatient adolescents by 50%. The second goal is to increase BPD patient and parent satisfaction within the 3 months of policy implementation by utilizing survey scales 1 through 10, 1 being the worst, 10 being the best. The team collaborators helping me with this project are my unit psychiatrist, a night nurse, the unit social worker, and myself. The PDSA cycle is a tool used for accelerating quality improvement. It helps test for a change by planning, doing, studying, and acting. The plan is to compile a team to help address the issue of recurring patients in our care, which I have done already with my collaborators. Research 2017 data of BPD readmissions and ER reevaluations 30 days post-acute inpatient admissions. I used the months of February, March, and April. Then I will plan to create a new safety plan and policy for staff and patients. To do or test the change, I will receive approval for suggested project implementation by my unit supervisor and director. I will have to educate all staff members of new individualized safety plans and begin utilizing new discharge policy for all patients. I will be attending team meetings regarding current successes and begin participating in family meetings. Instead of one family meeting being held at the beginning of their admission, an additional one should be completed nearing discharge. I must collaborate with outpatient mental health services for the discharge of the patient. and engage in one-on-one consultations with patients regarding feelings of readiness to be discharged. After all of this was implemented, we compared readmission rates in patients diagnosed with borderline personality from February, March, and April of 2017, utilizing the old discharge plan, to February, March, and April 2018 with a new discharge care plan. Of the 44 borderline patients who were hospitalized in the 3 months of 2017, 22.7% returned within 30 days for either an ER mental health evaluation or admission. Of the 56 borderline personality patients who were hospitalized in the 3 months of 2018, only 10.7% returned within 30 days. We also found a correlation between parent and patient satisfaction surveys. Surveys from 2018 were significantly better than the 2017 data. Acting on this information, I did revise the original safety plan to be more brief. The team members educated staff more on importance of family meeting and engagement. Individualized different safety plans for other diagnoses must be done, and approved second plan with team members and upper management. The new safety plan was sent to printing, and we began implementing a shorter one. Eventually, we will have to restudy those results. Additionally, I do have to begin comparing satisfaction of unit stay in correlation with our new psychiatrist. This is very important as it is hard to tell if patients or families are happy about their care because of the new MD on the floor since January 2018 or because of the new policy we implemented. The real change that this project had on the unit was the significance in the decrease of readmission 30 days post-discharge, as well as patient-family satisfaction of discharge care. In 2018, we cut readmission and reevaluation rate of 30-day post-discharge adolescent borderline patients more than half of what presented the year before. In 2018, we were also above average for all categories in the parent satisfaction survey and patient satisfaction surveys. Another change worth noting was the improved collaboration the team members adopted. The project really brought us closer on a professional level with our new psychiatrist. He was eager to help and educate all the way through. No one appeared to become discouraged or even ask, "Why are we doing this?" Rather, supported the implementation wholly. There has been such positive interaction with parents as well. Communication with them is much more open. We are not afraid to inform kids about their discharge and fear that they will act out or stay on the unit, and both family, patient, and staff feel safe discharging the child back to the community. Another positive effect of the individualized discharge change are less referrals being made to long-term state hospitals for patients with BPD. The barriers of this project included a few things. First, my manager is retiring. She approves just about anything, so it is hard to tell if what I am doing is correct or just to get it out of her way. Next, the emergency department staff and psychiatric staff have poor collaboration. It is hard to discharge a patient evaluated in the ER thoroughly because the ER staff pressures the psych RN to quickly do so. They are unaware of how much actually goes into discharging a high-risk person after denying them hospitalization. This makes borderline patients feel rejected. Without efficiently providing a plethora of support, the borderline can easily feel invalidated and displace blame on the RN. This can actually worsen their stability. Another barrier is that we are transitioning into a corporate company. I fear that eventually my safety plan will not be approved by whoever will be oncoming management. The fourth barrier is that our MD is very risk averse as he is newer to our floor. It is of course not bad to be very passionate about your career. However, it appears as though many ethical dilemmas are part of his decision-making process. And many times he really does heavily consider readmission of the borderline patient despite knowing it may not be best for them. The last significant barrier is that there are other children on the floor other than borderline patients. At times it is very hard to devote all of the professional's attention on one child when there is a major mix of disorders on the unit. My facilitators include the incredible support from my unit staff, the efficiency of my secretary to complete all the printing and aiding in data and collecting, and then, of course, the compliance and belief in the new policy. Now that my unit has been incorporating this successful safety plan, we are looking to train staff in the emergency department to do so as well. Though the psychiatric RN comes to the ER to complete the evaluations, many times ER staff become flustered wanting to complete discharge in a timely manner, as I have said so before. Since they are not specialists in this care area, it can be quite difficult to convince them that the discharge planning takes time. Without validating the patient, even by having them cool off in the ER for 1 hour, their symptoms could worsen and admission would be inevitable as mood begins to deteriorate with poor news that a borderline patient is not ill enough to be admitted to the unit. From spreading this change to our ED, we hope the company we are transitioning to will allow more psychiatric beds on either our unit or even the ER for evaluations. Borderline personality disorder, otherwise